what suggestions might you have for hope for changes in those funding streams to support public health? And as a setup for that, I'll tell you a quick story. My first job in public health was working at KU's Preventive Medicine in Wichita, and we had this MPH student who was 77 years old, a retired PhD physicist who came to me one time because I was the only person in the office, I think. It was just like, Sonia, why? Why do health departments do what they do? How do they know what to do? And I was like, I have no idea. I am a grad student, and I don't know why you were asking me. And so I would like to be the cranky 77-year-old in the future. Like, that is my highest aspiration, is to still be curious like that. And also, I had no idea. When I went to work at the health department, I was like, oh, it's whatever our grants and contracts tell us to do. So as we transform to 3.0 thinking, what needs to change? So I will just move right down the line. Thoughts about that?
Sure. So I'll start with what our health department's supposed to do, and just pass on advice that I got from Bobby Pestronk, who used to run NACHO when I became the health commissioner, and I was asking those annoying questions like, why do we have a local health department in New Orleans? And he said, look at the charter, look at the statutes, figure out what it is that you're supposed to be doing, that you're not, figure out what it is that you're doing that you're not allowed to do, and figure out what it is that you'd like to do but you don't have the authority to do, and then go work with your city council to make those changes. And it was a really great exercise, because though we were familiar with the essential services, it also reminded us of what the government, the public, the people had been expecting of us, and so I think that's always a good place to start, and that's why I like the foundational capabilities work, because it really kind of gets you back to the roots and makes you think about what you'd like to do. I think from a funding standpoint, I'll just make a general national federal comment, which is to say, I think a lot of times we think, whether it's the Washington folks or people in the front lines, that the funding for public health is somewhat coming from a hard money out of tax dollars, tax revenues at the local, state, or federal, the local or state level. But we looked at the CDC as the source of funding, as the public health agency, and I would really like to shift that thinking. I'd like to see HHS get to a place where it thinks that all of HHS has a responsibility for public health support, and in fact, I'd like then the next iteration of that to be that all of the federal government thinks that it has a responsibility. It's a relevant issue, right? Because when we have the public health partners with the Medicaid program, and there are savings in the healthcare system, those savings accrue to the healthcare system, not back into the public health system. If we do work with the housing system and their savings accrue to housing, then they don't accrue back into the public health or other systems. So just purely from a thinking about how we ought to be pulling other dollars as sources of funds, but then also making sure that it goes back into public health. There are international models where they've structured their programs to do that. In Australia, as an example, so it's not pie in the sky ideas. And there's also, I think, the opportunity for health impact bonds that was mentioned is a way that we need to experiment actuarially and get the health economists to help us understand how investing in third grade reading level actually is a public health function, and how that should come back to support health departments. So I guess I'm saying broaden our thinking about federal resources, and then we also have to do some hard work with economists and actuaries to make sure that we can accrue those savings back to public health.
I actually was going to make a similar comment, not as eloquently, about the need to sort of think about how federal resources get to local jurisdictions. One of our frustrations has been as you know, we love ACA as it has rolled out. There's been a lot of really important benefits for the larger kind of goals and vision of public health, but the ability for health departments to extract any resources for those to continue to do the work that they do that's going to contribute to that success has been really difficult. And some of the models that we early on thought might kind of provide those pathways, in fact, don't yet. And so I really hope that what you just described happens.
Well, ditto to that. When I was thinking about this question, I looked back at some data that we'd shared with our council on the future of public health. And one of those data points was that in Kansas, 23% of the funding for local health departments comes from fees, and a lot of that is for clinical services, that direct patient care, and that ranges from a high of around 50% for one health department example to a low of 10%. So it's varied across the state, but clearly this is going to be one of the major challenges that Kansas has transitioning to Public Health 3.0, is figuring out a funding stream to support that type of service delivery, aside and apart from our traditional way of relying both on categorical funding to support many of those direct client services, to a system where we're really more focusing on population health work, because there isn't one of those necessarily grant applications out there waiting for us to apply for it. So I think that is why it's so important for us to figure out this financial model about what will it take to fund these foundational public health services, the areas and the capabilities, so that when we go to seek that funding, to secure that funding, we can say with some definitiveness, this is what we need. And then for those of you that are familiar with the foundational public health services model, it does incorporate an opportunity for communities to say, these are specific community needs that we need to provide and support. And that's where we need to be looking at our local partners, including our local elected officials, to provide the funding to meet those direct community needs. So I think there's much work to be done in this area. It's already been called out that Kansas is very low in its per capita funding for public health, 47th in the nation, certainly not anything for us to be proud of. So I think this whole funding around both that growing and sustainable funding source and this movement to shift the funding equation to foundational public health services, Public Health 3.0. We've got a long journey ahead of us.
I would like to spend the rest of the day talking about this because it weighs heavily on my mind. And I guess the couple of points that I wanted to make were that, I said in my talk that this is a time for state and local action. And what I mean when I'm saying that is that as the states are thinking about the potential of per capita caps in Medicaid or block grants in Medicaid, or even 1115 waivers, special flexibility in Medicaid dollars that are going to really look at population health. This is when public health should be required to be at the table and should have a steady stream of funding from those mandatory dollars, not a special grant to do it, but just should be an expected funded part of it such that it will work. And I would love to see some states begin to think a bit like Idaho is, and the relationship they're doing with public health and primary care, and expand that even further. There are ways that you could model what it would look like that would change the way we think about the federal dollars we use. So when I say HHS itself is a public health agency, that means that we need to think of where the big pockets are, which is Medicare and Medicaid. I'm not saying that public health is a medical issue, but that there's a source of funding to improve health, and the statutes are broad enough that it probably can provide for care and services, and there's some nuances. And if you take a look at the report, you'll see some stuff that we recommended in Medicaid that's kind of worth looking at, and I'm hoping some states are going to take that up and want to act on it. And then I'll stop after this, which is about the data. We got it anyway. I mean, we've got to have better data. Healthcare has such good data; it's just killing us. And the county health rankings came out a couple weeks ago, and I got my final report card from my time as health commissioner. I left there in 2014. So that was so we're in 2017 now, but that's what came out. It has nothing to do with what we've been doing for the last 3 years as a community. It was a good report card. I was pleased about it, but it's really hard then to go to city council and say we need our revenue stream for something that happened 3 years ago, much less to the feds.
So I think that's a really important point, Karen, and I think that's one of our great deficiencies as local health departments and public health in general. We are operating on years old data, and so elected officials have a very short time horizon.
Right.
And so you go to them and say, we're doing this work, and they'll say, well, what are the outcomes, and when are we gonna see them? And they want them, you know, in 6 months, for an initiative that you may get positive outcomes in, you know, 5 months, or 5 years to 8 years. So this really is an ongoing challenge, but the outdated data that we often have to work on is really compromises our ability. And Sonia mentioned that in my prior job, we had a community health center that worked in tandem with our local health department, and it was so striking to me because community health centers, FQHCs, can really tell their story.
Yes.
And they do it every year. It's a requirement. They do the uniform data set, and it's powerful. And they've been very successful as a result of that, both at the national level and here in Kansas at the state level, in securing more funding, because they've got this powerful story to tell. And we're doing a different type of service, and so our challenges are different, but that was really stark to me in what a difference that data story can make in securing funding.
So it occurs to me that you all may have questions or thoughts or reflections that you'd like to ask specific to thinking about funding. So I wanted to pause and give it, I have another question I want to ask about partnerships, but let's be honest, that's a lot easier to talk about. As we think about funding, do you have questions or comments that you want to make given the dynamic conversation that just happened? Charlie?
Yeah, I'd like to follow up on some of the discussion that occurred yesterday around crisis-based funding. We've seen this happen over and over again in the last few years. It happened with Ebola, it's happened with Zika now. The problem is that we don't have the funding we need to perform a lot of basic public health services to handle anything that comes along. And then we get a lot of funding, more funding than we can really utilize in a short period of time. And this year with Zika in particular, we saw our basic preparedness dollars be taken away, only to be replaced by specific funding for Zika. It makes it very difficult. I think my concern is that the states are going to have a hard time utilizing all the funding that we screamed for. And in the long run, it's actually going to do us some harm. So I guess my question to you, Dr. DeSalvo, is how do we break that cycle of crisis-based funding?
I tell Sonia we shouldn't just admire the problem the whole time, and because I am very tired of doing that, though there's lots to say about problems, and you're hitting on one of them. This is, just like your lives are responding to crisis after crisis, in Washington, the secretary is responding to crisis after crisis for the most part, and a big chunk of his time, then her time, was also the Affordable Care Act, right? So there hasn't, in the absence of a really clear story about what public health is, saved your life today, you didn't know it, whatever, whatever definition we're going to use, and these are the foundational capabilities that every American should have access to. Here's the gap in providing that. Here's how we're going to help everybody get there. It's just crisis funding. So I don't, in the short run, I'm not sure that we're going to see a lot of change in that space until the public health community. And Sonia and I were talking about this morning. I mean, I think it's not just those of us on the front lines, but the leadership of the major organizations. I've encouraged them to sit down and say, this is the vision for public health, this is how we need to get there, and this is the roadmap that we're going to create and get buy-in about. Because what's happening right now is most of what's heard in Washington is it's about the prevention fund. And the prevention fund is considered a slush fund. It's always been considered a slush fund. And worse yet, what they hear in Washington is that there's crisis and then there's grant programs. So they only, the sense in Washington is there's not a foundational thing that happens every day. I don't want to depress you all or leave you in a bad place, because I do firmly think that the reason this country is as great as it is because we have public health. I mean, this is, you cannot have a successful economy and a strong military and everything else that we have unless you have potable water, right, and a sanitation system and vaccines. So, but that story's not translating well. And de Beaumont's gonna do some work on trying to get a better narrative, which is a start, but the money and it is where it's at. So if I have one piece of advice about this, I think it's that, again, to spread the communications at HHS beyond CDC, the pathways either to ask for preparedness and response or to CDC, that's where people go to talk about public health. So Medicare is not getting a lot of income or SAMHSA or HRSA, and it would be really helpful for those leaders to understand the value of public health in every day, not just in disaster. And that, I think, would begin to spark some internal conversations that would be more helpful. And the more clear we are in message and in numbers, I think that the more successful we'll be. But it's a long game. It was mentioned earlier. This is not going to be a short game, but I think it's worth a long game, and I want us to really move for that.
Susan or Lougene, either one of you want to? All right. Dr. Pizzino.
So I want to take you up on your challenge of asking difficult questions. So here's mine. There are roughly 2,700 health departments in this country, give and take, depending which day you count. Can we imagine a day when there will be enough money to support foundational public health services for all of them? And even if we had that much money, is that the most efficient way to do it?
So the question is it the most efficient way to do it to fund all 2,700 health departments to do foundational public health services?
For
Consolidation, regionalization, shared services.
resources even outside of consolidation.
Yes, yes, and yes. And as I'll start, and these, they can jump in. I believe that there has to be, that there must be. I think in a world where we have digital supports and technology supports that can allow for cross-jurisdictional training and data sharing and other supports, we don't need maybe as much, in some cases, redundancy. I'll pick on Texas, where there's a lot of redundancy. Some people have proposed what's the right units. I wouldn't purport to be an expert in that, but I do think that in reality, we're going to have to probably have some consolidation, just like we've had in healthcare. I think we learned that lesson. Sometimes I use primary care as an analogy to public health. It was where I spent a lot of my career, and some examples of the analogies would be that in primary care we would say we were good, but it wasn't until we had accreditation for medical home that an external body could say we were good, and then the payers were more willing to pay for it, and then the actuaries figured out what it would cost to provide good primary care for every person, not for every doctor, right? It was the flip, and that led to now Medicare being able to pay for it, and primary care, I think, is on a pretty good pathway. It has an opportunity. Public health, in a similar vein, it needs to get away from saying, what does it cost to fund the jurisdictions? What does it cost to provide good public health for everybody in the country? Once we have that number, then we can, I think, work backwards and figure out how to fill the gap.
Well, we're obviously, as I said, a regionalized system already. That doesn't mean that there aren't also opportunities for us to do cross-jurisdictional sharing, and that is something that actually our health departments do in part through their SACHO, their NACHO affiliate. I think that in our case, we weren't in a situation where there were a few existing health departments that became part of larger districts. And actually, most recently, we did have a county health department. We had two sort of standalone county health departments that now we're down to one because that other county has decided to join its surrounding district. So that can be done. And I think the reason that it works in Nebraska is because we have taken that chief health strategist approach, and that chief health strategist approach is about regional thinking. It's not about county thinking or city thinking. And because a lot of our health departments are using collective impact as a model, they've got buy-in from communities. And so even though a community may be part of an 11-county health district that's bigger than the state of Connecticut, they feel ownership for that particular entity. And so it works for us. But there continue to be opportunities even in that regionalized system for sharing. And you guys have a very different situation.
Well, we do, and John Franco certainly knows that, and I think you all have a we have things that we can learn from you. I mean, I don't see, John Franco, from my point of view, that we can get there in Kansas, let alone across the nation, with these very small health departments. That it's going to take some other kind of model, that it's going to be a difficult journey in Kansas and probably in every other strongly decentralized state. And I would describe Kansas as a very strongly decentralized state with great passion for home rule. And even our local boards of county commissioners who serve as the Board of Health may not care a whit or know anything about health or public health, but they certainly aren't willing to cede the responsibility and authority. Sorry, I have my own story about that from when I was in Lyon County. So it's going to be a journey that's not going to be painless, but I think it's really we're going to have to look at those different models for governance in order to get to an effective way of assuring those foundational public health services for all Kansans and extrapolate that to the country.
Excellent. There's a question right here.
I just have a quick comment, actually thinking back to Public Health 1.0 and 2.0 and the role of clinical service delivery. I think we've seen that declining over time, and what do you guys see happening in the future, particularly in the delivery of clinical services that maybe in the past the health department has been somewhat uniquely positioned to deliver? And as that relates to like third-party billing even, so what's going to happen with that?
So that is such a great question. And here in Johnson County, we actually do a lot of direct client services, clinical services. I think our revenue, I don't remember the percentage, but it's probably in the neighborhood of 20% or so of our budget. And as much as I believe in population health services and moving more and more to this public health 3.0 model, there's 7,000 to 8,000 women that we serve in our family planning and STD clinic and our prenatal services that would not have a source of care if we said, okay, closing our door, we're done, we're just all about population now. I don't know how we get there as a county, and it will be a journey. We have an FQHC now that is growing, but they don't have the capacity to absorb that kind of a caseload just overnight. So I think in other smaller health departments, it's similar. They do that because they are the source, and I worry that. Depending on what happens at the federal level with the Affordable Care Act, if that gets rolled back in a significant kind of way, I think that unmet need is going to escalate again. We would have maybe a totally different picture here in Kansas if we could get to that Medicaid expansion, but we'll see what happens in May. So I don't have a really great answer to that, but I do think that is one of the looming questions in front of all of us here in Kansas that are still doing those direct client services.
I'll just add quickly, like I said, most of our health departments do not do that much direct client services, sort of pieces of things here and there. But one of the things that concerns them about the idea that there would be even less of that is the optics and the telling the story, because those direct client services are very concrete. And why we're so bad at telling our story in public health is that a lot of what we do is kind of squishy. And so losing that concrete example of this is what your health department does is something that is concerning, even at a time when they are taking on that chief health strategist role.
I'm of the mind that health departments should not be providing direct clinical services, because I think that is a barrier to being a convener of stature around access to care issues in the community, because the healthcare providers perceive you as a competitor. And with that philosophy in mind, when I was health commissioner, we pulled out of healthcare services with a couple of exceptions, so now you're getting to hear me talking out of both sides of my mouth. I have gone to our FQHC 330 homeless designation, and because lots of people in the community wanted to take it, and I wouldn't give it away. We continue to provide care because I felt like it was my just in case that we didn't have Medicaid expansion or something else happened. I wanted to make sure the health department could step in and provide service. So I never fully reconciled that. I always left a little something in my back pocket. That if you know me, you'll know that I'm that way. But I also, this gets to the data thing for me because with the hospitals directly, I was also building a hospital. That's another story. But it's not another story, it's this story. I was building a hospital, so the hospitals would say, yeah, we know that you want this geocoded data on asthma admissions so you can target the kids in the community and see which schools and housing developments are having environmental health issues to go help children, but we're not going to share that with you because that's a competitive data and you're building a hospital. And I think that my hope is that in communities where they back off, that there's more access to data. By the way, there are some happy models of good data. I don't want to say that there's not, and I would point to places like Allegheny County. But if you're interested in finding some places where they do have better access to it. It's a real problem when you find a disaster and you don't have any nurses or doctors there.
Yes. That's a live issue. That I would also add on the data point, when Becky was sharing about Public Health Sister City, one of the big aha takeaways for me was that Oklahoma was among the first grantees in the health information exchanges and built a robust health information exchange. And Dr. Dart, who's the director at the Tulsa City County Health Department, can pull up a dashboard on his screen daily and take a look at I can't remember if it's at the census tract. I think it's census tract level. The folks who have been recently diagnosed with diabetes, so that they can do more targeted outreach for public health. I mean, they have real-time data about that. So there are models that get funded and get built, and it was a huge statewide partnership, and I don't have all of those details, but I'm just saying that we can get there, but it's not a slow and easy road. I mean, it is a slow road, and it's a very difficult road. Dr. Bukanda, you had a question.
I would like to thank you for this opportunity. For me, I think this conference has been an opportunity to learn about what is taking place here, but at the same time as I'm listening to the presentations and questions, my mind kept thinking about what I'm coming from and what I've seen happening there. I am originally from the Democratic Republic of the Congo, and I'm a faculty member at Wichita State in public health. Dr. Pauli was my chair. So the question I'm asking here is related to this process of developing local public health department. I have seen something in the 1976 with Alma Ata movement, instead with primary health care. I've seen in the Congo in particular a process of redistricting the country to make health zones with medical doctors being in charge of the health zones. So I'm seeing like a replication of something that is already taken place 30, 40 years ago in most developing countries in Africa. So I'm just curious, is any connection being made to see what has been the experience of those countries and what is happening here, or is it just a separate process without any consideration for what has been taking place outside of the US?
Yeah, you know, in the U.S., medicine and public health began to separate around the time penicillin came into being, and medicine became a fixer, and people in this country really liked that. And then we got cardiovascular interventions and dialysis, and over time the funding increasingly, especially what we call mandatory funding, no matter what, you're always going to get it, to medicine. So 97% of our health dollars go to medicine. Public health gets about 3%. even though it's probably could impact 80% or more of the outcomes. So, so there's an imbalance, and as they got divided, they divided their schools of training, their conferences, their vocabulary, their literature, and we've kind of forgotten about each other. And quite honestly, in the U.S., when we say public health, people often think of public hospitals, so government-run hospitals or health centers, or public health care like Medicaid. So though public health is strong and does great work in the U.S., it's been really kind of disenfranchised. And I'll just add another layer for you, which is that even at the state level, there was a movement in the 80s, I think, someone helped me with this, to separate environmental health and social services and Medicaid from public health. So they're all separate parts of state government, and sometimes at the local level. So things that public health used to oversee are now all splintered, and the funding is all over the place. The movement is to bring it all back together, including with medicine. But medicine still in the U.S. doesn't have a public health agenda. They make more money if people are sick. And though we're trying to change that in the country to reward health, they still have a different whatever. And so there's a mission misalignment. Do you see what I'm saying? And so though countries, I don't know as much about yours, but I was recently in Cuba, where the public health department, every medical system, academic health center, the hospitals, everybody reports to the public health official in that district. And they're really thinking about the population health. I can speak most recently to that, but I know that you're right. In other countries, we haven't separated medicine and public health like we have in the U.S., and I think what we're all trying to get to is how do we get back together.
Thanks. Rua?
Yes, speaking of other countries, I'm just curious, I know that coming up in May, the World Health Assembly will be meeting, and one of the priorities for the United States is to discuss security and the U.S. leadership in the world. And I'm wondering, as we face these challenges in our country, what do we do to retain that leadership role, because the rest of the world sees the United States, contribute to the funding of the World Health Organization. So what can we do, or what challenges do we face within that? How do we keep being a leader in the world in the environment that we're in?
Wow. Nobody's fighting for the mic on that. That's a great question.
That was a really sophisticated question and an important one. Let me just first spotlight for you that this idea of global health security, the global health security agenda was started in the Obama administration. It was the priority then. It will probably still be going forward. It relates quite a bit to communicable disease, so public health 1.0 type work, and thinking about things like antimicrobial resistance, but also the threats of globalization. And I say threats meaning bugs jumping across borders. And I will continue to be a leader in that. The career staff who are engaged in the global work are extremely experienced, and they involve not just HHS, but USAID and State Department, and I think they understand what's on the horizon. What's more at risk there is an economic issue. So if you're interested, maybe it sounds like you're pretty aware, but I think there's a lot of the pharmaceutical industries really interested in how they get funding for antibiotic development, because you're all over it. And so, however, I think that I just might add that from a World Health Assembly standpoint, I talked about Public Health 3.0 there last year, and I had sort of this, people were like, what are you talking about? Like, that's exactly how we do this every day. And I'm like, I never get it. So I do understand that globally we're ahead and behind at the same time. But the good news is that a lot of communities are getting back to what I would call basics, but doing it using new tools.
So, thank you. I'm going to pull it back to, because I think one of the important reasons we come to this work, to spend time together like this, is for a bit of inspiration. So one of the things that we all do, one of the things we're called to do as a recommendation in 3.0 is to develop new and strategic partnerships with new and different partners. And I think it was Rex yesterday that was challenging us. Like, it's great when the local health department works with the hospital and your local health coalition, et cetera, but who's your next more strategic partner to help work on things that are related to all of those social determinants of health and that focus of 3.0 that Dr. DeSalvo was just pointing out. So I would like to start on the end with Lougene, and I'm curious, like for each of you, like what is one of those unique new strategic partnerships that you're pursuing to try to develop that 3.0? And I know you're doing some cool work.
Well, thanks for that vote of confidence. You know, one of the things that we're doing, we've recently, under the leadership of James Yorkie, Deputy Director for the department, about a year and a half ago now, we formed a Health Equity Council, recognizing that these issues of health inequities are just something we can't continue to act like, well, somebody else is working on that. And so we're now hoping for a successful grant application award with a not-for-profit in Johnson County, United Community Services of Johnson County, to build a broader coalition of folks working on health equity issues. And so the partners that we're looking at now are some of the minority-led organizations like the NAACP, El Centro, which works with Hispanic people in our community. There's a Latina Alliance. So we're really working on building some relationships with those, and not that we've never worked with them in the past, but a much more intentional and hopefully what will be an ongoing relationship. So that's one example.
Thank you very much. Susan.
I'm the wrong person to answer this question because I am not in the trenches. So I spoke briefly about at the SHO level that we have been working with our veteran and military families statewide, and that has resulted in a lot of new coalitions being built or coalitions being broadened, existing coalitions being broadened to include, in some cases where public health was part of a coalition or a group that was already working related to the National Guard, and other instances where the health department has kind of acted as a backbone to sort of set up coalitions that are more inclusive, thinking about whole community well-being. In rural communities, disparities are, being in a rural community is a source of disparity. And so kind of addressing some of the, approaching rural communities and kind of broadening the reach of public health, as well as making new friends in public health in that way. I know that a lot of our members, through their points of impact work, are working with economic development agencies in their regions, and an interesting partnership that's related to that, and I don't know who all the partners are with this recently, but related to national news in White Clay, Nebraska, which is our embarrassing beer selling little town on the border with the Pine Ridge Reservation. The health department has been involved in work in and the state has funded work to demolish a couple of homes or buildings there that had been sort of sources where people were just going to be inebriated and was a public safety threat. And so this has been sort of part of their role in kind of chipping away at that decades old and horrible problem there. So.
Did you see what just came across?
No. David's going to give us an update.
The Liquor Control Commission denied their liquor licenses.
Wow.
Today.
And we won.
So I think Susan proved that she was exactly the right person to answer that question. And I really love that you elevated the work with veterans and with the military. We have veterans and military in every state, right? And our military partners are fantastic at public health. They have 100% vaccination rates on those bases, and fluoridated water. And also Fort Riley in Kansas just was a national pilot for testing the accreditation standards in military public health, and their site visit was just in the last month. So there's good work happening with those partners, and we don't always think about working with them. And the health coalition that I helped lead in my community never once effectively reached out to the Air Force Base right there in my town. So these are new partnerships that are cool opportunities. Thanks, Susan.
Yeah, I I love that one too, and I was gonna answer for Susan, because she told me some other partners that she had issues. I think it depends on the public health challenges that you have in your community and what the priorities are. It may be the criminal justice system, it may be, veterans. So I think that will vary somewhat, but I would just remind us that public health has a goal of healthy communities and healthy people, and so does the business community, and so do payers. They're natural partners that we don't often link into. The other interesting work that I think as partners is technology companies. They're very hungry to do something meaningful and be engaged in community, but they don't quite know what to do. So, for example, I was at Cerner yesterday, and they're really interested in learning more about public health and what's happening. They're working in Nevada and trying to sort of think about a community level health. GE's doing stuff in Boston and other communities. So big companies, but I think also your local chambers, I would encourage some development of relationships. Also because they tend to be closer to the elected officials, and that is obviously helpful when you're going for budget or other resources.
I'll take the mic. All right, so this was, I hope for you, a stimulating time. I wrote down a bunch of notes trying to keep up from the front. So thank you to our panelists, first of all. Thank you very much. We have an opportunity to transition, so we'll spend the next 15 or 20 minutes or so getting lunch in the buffet style that you have become accustomed to out there. And we'll start back in here about 12:20 with our partners from Nebraska and Missouri, talking about how do we build a workforce to do all of this great stuff we just talked about. All right.